Well, I want to welcome everybody to our continuing curriculum in ophthalmology, sponsored by Rush here and facilitated by Meeting Achievements. This is our third session. We designed this course to be a 2-year continuing curriculum in ophthalmology. Each one of these courses, which will occur every 3 months for a year for 2 years, and each one is based on a subspecialty within ophthalmology. So we've already had a continuing curriculum course on oculoplastics, and our second one was on cornea, and our third one tonight is on retina. Followed by that, July 8th, we'll have glaucoma, and then pediatrics, and so on. And the schedule will be posted on the website, and you'll get notifications of our upcoming programs as well. So this event is worthy of Category 1 hour of CME credit, and you will be getting afterwards from Meeting Achievements an email on how to apply for that CME credit. So look out for that coming in the next day or so. My partner in designing this course has been Dr. Sarin. Dr. Sarin is in charge of education for the Department of Ophthalmology and assistant professor of the subspecialty in glaucoma. I'm going to introduce Dr. Sarin now so she can take it away and give us some of the specifics of how the format for the night will run. One last thing to remember, and it was on the slide ahead of time, if you have questions, we want this to be somewhat interactive when we have our discussion after the case presentation. And the questions that you give us or for the panel, please put in the Q&A box, not the chat box, but the Q&A box. So Dr. Sarin, why don't you come on and you can introduce the specifics of how tonight's going to run.
Right. Thanks everyone who logged on tonight. And a special thank you to everyone who is joining our panel. The last 2 sessions have been really, really great conversations, and I'm very much looking forward to the conversation we have tonight in the area of retina. So the format for today, we're in a few minutes, we'll hear from our Rush resident who's going to present a case. That will give us a lot of food for thought. And then we're going to have a breakout session with our exhibitors from Astellas to give us some information about their product. And then when we return from that, we're going to have a few poll questions just to, again, kind of get everyone thinking about their treatment practices and their referring practices when it comes to macular degeneration. And I think that will lead into some great discussion amongst our panel. So we really encourage questions from everyone who is logged in. As far as our guests tonight, our panelists, we have Dr. Alexandra Rachinskaya joining us today, and we're going to get a more formal introduction from her from Dr. Chaturvedi momentarily. Dr. Chaturvedi is our section head of retina for Rush University. And then the other members of the panel we have tonight are some of our most esteemed members of Illinois Retina, whose accolades are far-reaching, and we're really grateful for all of you coming on tonight to share expertise. Dr. Matt McCumber, Dr. Koros Rezai, and Dr. Raymond Lee. So that will be our panel. And then at this time, I'd like, and then again, you'll get an email with the CME credit application for tomorrow and the link to the webinar in case you want to watch it or share it with, kind of get more knowledge, watch it again. And then as far as our case for tonight, we have Dr. Rishabh Gupta, our PGY3, who is interested in retina, who will be sharing a case tonight about macular degeneration. Take it away.
Thanks so much, Dr. Sarin. I appreciate that. I'm going to go ahead and share my screen here. All righty. I'll move this over here. Okay, well, let's get started. Thanks for having me. I appreciate the panel for being here and everyone here who's attending. My name is Rishabh. I'm a PGY3 resident at Rush, and this is my case. So we have a case of age-related macular degeneration. So a little bit of a spoiler, but you guys already probably knew that. We're going to go ahead and jump in here. Our history: 47-year-old female who presented to a Midwest Retina clinic as a new patient referral for age-related macular degeneration. This was in 2015 that she presented with a non-contributory medical history, no ophthalmic or past ocular history, but did have an extensive family history of AMD and was referred from her primary eye care provider. Her only history at this point in time is mild blurring of the vision in both eyes that appears constant, but otherwise no complaints. She's 20/25 in both eyes. Her anterior segment exam and base ophthalmic exam is normal. So I wanted to give you guys just a fundus photo at the time of a presentation back in 2015. We have great photos here today in our presentation. And so as you can see here, we see a fundus photo of the right eye on the left side and a fundus photo of the left eye on the left side. And our attention is drawn to the macula where we can see what appear to be small or intermediate sized drusen that are kind of in the macula. And there's numerous ones, as you can see. Here's the OCT in 2015 at that time. Again, right eye on the left side, left eye on the left side. We can see what appear to be these drusenoid deposits that are in the space between the RPE and Bruch's membrane there on both sides. There's a few of them, but the outer retina looks intact, the inner retina looks intact, and the OCT otherwise appears unremarkable. So at this point in time, really briefly, any recommendations from the panel that you'd see if you saw a new referral from this kind of patient?
I think this is, first of all, thank you for presenting this case. This is a case that I think all of us see probably multiple times a day, and something that we can continue to learn from. And in my opinion, this is a patient that I commonly see in my clinic that is referred to retina. And I think it's good to establish with the patient kind of the plan going forward. This is obviously the patient that I'm not too concerned at the moment, but they're young and they already have macular degeneration. So my standard evaluation, I would ask patient about their family history, about their smoking history. I would ask if they've been using medications such as pentosan and Plaquenil, because that can affect the retina as we continue going forward. And my recommendations: the patient has drusen, they have intermediate type of macular degeneration. So I go over AREDS2 vitamins. I talk about sun protection, sunglasses, hats. I talk about Mediterranean diet. I talk about smoking and avoiding smoking. So that's kind of my talk for that type of patient on the first presentation.
That's exactly it. And that's exactly what was recommended to this patient. Smoking cessation, as you talked about, workup for alternative pathologies. And then as you spoke about as well, really briefly, the AREDS2 vitamins. So as has been shown, the AREDS2 vitamins have these micronutrients that have been shown to reduce the risk of progression to advanced AMD at 5 and 10 years. And that's well documented with the AREDS2 research group. So this patient was recommended AREDS2 vitamins, smoking cessation, and Amsler grid for monitoring visual symptoms, and then also follow up as well. Going on forward, I took a time point here 3 years later from her presentation. So as we can see, the technicians documented her Amsler grid. She's starting to have these kind of wavy little distortions that are kind of near fixation in both eyes. Her vision actually is still very good, 20/20 in both eyes, and her exam is otherwise unremarkable. Posterior segment, because we don't have a fundus photo for this point in time, does show some increased soft macular drusen, many intermediate, some large, but no hemorrhage or obvious subretinal fluid on the examination. So let's look at the OCT together here. On the left side, you have the right OCT. Left side, you have right side, you have the left OCT. Left side, you have the right OCT. And so you can see here that there's a significant increase in the amount of drusenoid deposits between the level of the RPE and Bruch's membrane. But as you can see, that photoreceptor layer appears a little bit shaggy, but we don't seem to see any sort of other outer retinal or inner retinal disruption at this point in time. So this is in 2018. I'm going to go ahead and keep going on with the case for the sake of time here. Like in 2021, we actually see 6 years after the initial presentation, she still has these stable kind of distortive lines that are near fixation here, as you can see from her Amsler grid. Her base exam actually still has very good preserved visual acuity. Anterior segment exam continues to remain within normal limits. And now this patient was 47 at the time of presentation in 2015. At this point in time, the patient is only 53 years old. We have great fundus photos. And I actually did this eye, I wanted to compare both eyes at this point in time. One from her initial presentation, from the photo you saw on the right eye in 2015, and on the right side, you see the same patient right eye photo from 2021. As you can see, initially she had some soft inner and some soft, small, and intermediate sized drusen that have now become a significant increase in the quantity of what appear to be these soft, intermediate, numerous drusen that appear to be there in the macula. Otherwise, the macula appears to be normal with no obvious subretinal hemorrhage or fluid that we can see on the examination. Very similar findings here with the left eye fundus photo comparing the 2015 on the left side with 2021 on the right side. We can actually see just a significant increase throughout the macula, and you can even see that temporally in the macula there, where there's a significant increase in the amount of soft and intermediate sized drusen, and actually a few large drusen as well that we can see that are starting to really have these early signs of coalescence there. So at this point in time, the patient was still received a diagnosis of intermediate AMD. Now, here are actually some infrared photos that I actually wanted to capture here as well. So this is still in 2021. We have both eyes here side by side, right eye on the left side. You can see these intermediate drusen there that are kind of scattered throughout the macula at this point in time in both eyes, but otherwise no other significant findings that would indicate any progression to advanced AMD at this time. Here's a comparison of the OCT in the right eye that will help us a little bit more. And again, just showing a numerous increase in the amount of drusenoid deposits between the RPE, Bruch's membrane, and it looks like the photoreceptor layer and RPE layer are still relatively preserved, although albeit a little shaggy. You can kind of see on the right picture on the right side, but they appear generally preserved here with no hypertransmission defects. And a similar finding with some progression here on the left side of the left eye. Okay, and that brings us to about 8 years after her initial presentation. So at this point in time, she's continuing to actually report distortion near fixation. This is actually worsening slowly for her, and she's been noting this and is very symptomatic about this. Base exam remains preserved with a 20/25 central visual acuity, and her anterior segment exam remains unremarkable. Now, I wanted to show the infrared photos here first, because as you can see from 2021, the infrared photos that we saw previously earlier in the presentation, there is a little bit of a difference here. Can any of the panelists comment on infrared photos and really very briefly their role in tracking AMD and what's kind of briefly seen here?
Yeah, so I actually find that infrared photos or near infrared photos really helpful in clinic. This because for the most part, all my patients get OCTs, and this just comes with the OCT scan. And especially in this patient, you can see how helpful it really is. From 2021, you really don't see any obvious signs of geographic atrophy, maybe something nasally. But if you look at the 2023 photo, definitely more areas of concern for geographic atrophy. I find this really helpful because it's really easy to kind of compare previous photo scans to. And obviously, you can't rely strictly on the near infrared to confirm geographic atrophy, but if you get the B scan across, those certain areas of likely geographic atrophy, and you see the hypertransmission defects, those are really helpful in making a clearer diagnosis of GA.
Yeah, makes total sense. So we have the right eye, and as Dr. Lee pointed out, significant kind of areas of hyperreflectance that we're now seeing in the 2023 photo that we're not seeing in the 2021 photo. Well, this is the right eye, this is the left eye. And so as you can see, significant progression in the matter of 2 years from what appears to be intermediate sized drusen there on the left side to what appears to be kind of geographic atrophy. And you can see just from the infrared photo. Obviously, the OCT is necessary and very helpful at this point in time. Now, interestingly, I actually got the horizontal cuts, and as you can see in some of the infrared photos, there's only one part of the atrophy that you're seeing in the infrared photo. And actually, this is the right eye, so this is kind of cutting towards the end of the scan here. And as you can see in the OCT of the right eye, as Dr. Lee pointed out here and kind of mentioned, we do see there kind of nasally in the macula hypertransmission defect. I'm not sure if you can see my mouse here, but I'm going to kind of hover over this area where you can see this increased reflectance through the level of the choroid and the choroid capillaris. That's really kind of telling about this progression of this lesion. And then here is comparison from 2021 and 2023. Sorry, this should say OS. That's OS from 2021 to 2023. That progression as well. As you can see, this increased hypertransmission defects there, the nasal macula there. And so this is 10 years after initial presentation. This patient was actually at this point in time, and actually so at the previous point in time, was actually recommended treatments for advanced AMD with Izervay at this point in time. Now, can someone comment really briefly on a couple different things? You know, I know it's more of an extensive discussion about treating a patient for this, but at what point in time do you guys consider having this conversation with the patient, and what brief factors go into that conversation?
Yeah, I can comment. Excellent case so far, and a dramatic occurrence of geographic atrophy, or mainly in the left eye. I think the patient is becoming symptomatic, and that is one element. Also, if you have this history of scans, you can show the patient the rate of progression of geographic atrophy, which would help them make a decision. So at this point, there were two drugs available, pegcetacoplan or Syfovre, and avacincaptad pegol or Izervay. And it is reasonable to bring that up in conversation. The patient, it takes fairly lengthy discussion. So certainly if patients have this degree of progression, you see the transmission defects, indicative of the geographic atrophy. This is where the comprehensive ophthalmologist certainly should refer the patient to a retina specialist, because these drugs can slow progression of geographic atrophy, and it's certainly something that the patient would be interested in at this time, particularly for that left eye.
Yeah, and I think that makes yep, and that's exactly what happened in our case actually as well. And this patient was offered Izervay. Actually elected to proceed with Izervay in the left eye only. And at this time, which is the most recent follow-up she actually has in 2025, was received 3 monthly injections at this point in time. And she still did have some progressive worsening visual function. And because I had 2023 scans to show you guys, I did still want to show you guys some scans from an earlier point in time compared to a later point in time. So as you can see from 2021, still in this very young patient, we do continue to see some increased changes on the infrared scan, as Dr. Lee briefly discussed. That's the right eye, and here's the left eye from 2021 to 2025. Extensive changes on the infrared photos here, as you can see. I know I briefly commented on the OCT, but would one of the panelists like to point out changes on this OCT that you're seeing from 2023 to 2025 here?
Well, I mean, the main comment that I would make regarding the changes for this right eye from 23 to 25 is not just the nasal part where you see the transmission defect kind of on the right-hand side that's increased, obviously, but the drusen effectively throughout the entire scan are slowly disappearing. You don't have transmission defects, but the patient, unfortunately, is on the precipice of probably having pretty profound GA, unfortunately, pretty quickly. And The far the lone drusen that's kind of by itself is probably a calcified drusen, that little one that's sitting there temporally on the right on the 2025 image, and that's probably going to collapse pretty soon too. So unfortunately, these are all kind of going pretty closely at the same time and also pretty rapidly, unfortunately, as well.
Yeah.
And just to add, the ellipsoid zone, which, as Rishabh mentioned earlier, the photoreceptor inner segment layer is really becoming significantly less distinct throughout the macula, a precursor to thinning of the outer retina and GA.
Richard, did you say she was still 2025 at this point?
Correct. She was still 2025 at this point in time.
Is that an expected level of vision for this OCT?
Yeah, many times it takes a while to the center of the fovea getting involved. So these patients can have, when they come to your office, they can see 20/25, but that is just the visual function. The functional vision is very poor. They have difficulty reading, driving, because they have a lot of scotomas. Basically, all these areas that Rishabh showed, you see this hyper fluorescence where the light can just transmit straight through. This patient cannot see, as Matt pointed out, because there's both RPE and ellipsoid zone defect. This is a very unique case because it's we talk about age-related macular degeneration, so we expect this patient to be elderly, but this patient just 48 years old. So this is a very early stage. Usually in clinical trials, the cut point for age is 50, and this patient is actually 48. So, and the other part is that, as you showed earlier, you have multiple foci of GA. So multiple foci is a sign that is a fast progressive. So that's a risk factor. One other imaging modality can be very helpful is autofluorescence. When you do autofluorescence, on those images, you can also see at the border of the images that the type of fluorescence they have would also indicate that how quickly they progress. This is probably a patient you may want to treat in both eyes, and you probably want to treat aggressively. I know Vivek, a year or 2 years ago, told me something that I actually tell all my patients now, and that is, if you live long enough, you're going to lose your central vision. So when do you want us to slow you down? These drugs slow down 15 to 20% a year. And, if you're going to reach a cliff, when do you want to be treated? When you're close to the cliff or when you're the furthest away? And I think you probably want to be treated as soon as possible to prevent the progression, especially in the aggressive case.
Yeah, very aggressive case here. And one of the reasons I wanted to present this case was obviously not just because of the great photos that we're seeing and with really great comparisons of very rapidly progressive AMD, but also the idea that, even in young patients, this can be a very aggressive disease. And so it should be very closely monitored. We should have an extensive discussion, counseling about AMD, and refer to a retina specialist as necessary when the time comes. And so we obviously see a lot of early AMD in our clinics, in the resident clinic as well. We obviously do monitor in the retina clinic. And so I do think in the private world, referring to a retina specialist and making sure it's monitored is the great move. Any other brief thoughts about?
Reed, there's one question that comes from Dr. Ki Wong, who sends a question from Florida, which I think would be a good question to give to our panel to kind of start some of this discussion. And he's basically asking, what modality do you best use to try to diagnose drusen and the progression of drusen? And we've talked about all these, but is it examination in the office, 90 diopter lens, for example, or is it color fundus photography? Is it infrared photography, or is it OCT? What's the best way for a non-retinal specialist to start to follow these patients with drusen?
I can get started. So I think when you follow these patients, I would recommend using OCT. It's an easy test to perform. It's easy for the patient. And as we were talking about this particular case, I actually reminded myself that as we started learning more and more about geographic atrophy, as the clinical trials were happening, I realized how many patients might have some early geographic atrophy that we weren't paying attention to. And having the old OCTs, the historic OCTs, and looking at that en-face image, as was shown beautifully in the presentation, really kind of educates you on the progression of geographic atrophy for each particular patient. As Koros has mentioned, getting fundus autofluorescence gives you beautiful images of geographic atrophy, but that's not something that is done routinely, even in a retina practice. You might get it once a year or twice a year, but OCT, we learn more and more looking at the en-face image and not just at the B scan. And I think we also realized that a lot of our patients progress much faster than we thought they were originally, because before we had any treatments, we did a study where we looked at the patients who were diagnosed with intermediate age-related macular degeneration. Then we looked back how many of them had atrophy, and it was surprising the percentage that had atrophy. And it's just because there was no treatment, right? And we weren't looking for it. So I think OCT is probably the best way to monitor those patients. But as has been mentioned, I would just highly recommend looking at both images because it will give you more information.
It's a good point because as you're even saying that, Alexandra, it's when a comprehensive or general ophthalmologist sees an OCT, they see hyporeflectivity on the OCT, they worry that's fluid, and they refer them to us. But similarly now, if you see a transmission defect, that should be a reflexive. Hey, we probably should send this patient because they already have some atrophy, for sure in that case. And so, just like seeing fluid on an OCT should be a reaction to send a patient to us. I think seeing those transmission defects is another reason to send patients to us right away. So OCT is definitely the easiest one to probably use.
And if I could just add, looking at the raster can be helpful, or the en-face image, as Alexandra mentioned. But if you have time, try to go through all the images because you may pick up transmission defects that are not central. You might also pick up a little subretinal fluid, for instance, or intraretinal fluid that you might miss otherwise. So it is useful, particularly for the retina specialist, but also the comprehensive ophthalmologist to go through.
Yeah, I think Dr. Sir mentioned that, there's always general ophthalmologists concerned that they're flooding our clinics, and that's just not the case. I think specifically for something like this, even though it's really early diagnosed GA, I think having the conversation with the patient is really important too. They might have a tiny amount of GA that's really far from the center of their vision, but I feel like treatments for GA, this is just the beginning. I imagine more and more therapy is going to be available. So just even having a chance for the patient to see us and just have a discussion about treatment options is always very helpful for them.
I think I just want to follow up on what you just said, and it came up during the presentation, is when do you start talking about treatment, right? And so my whole approach of so the patient comes in, and usually the patient is very anxious. They might have just, maybe a few drusen, but the diagnosis of age-related macular degeneration is very scary to a lot of patients. So I think it's important to recognize that as we educate our patients. And so I used to talk about wet and dry, right? You have dry, this is good. You don't want to go wet. If you go wet, we might need to start injections. And I really changed the conversation from the beginning and started introducing the notion of geographic atrophy. So I talk about how the disease can stay stable, which happens to a lot of patients, or it can progress in more advanced stages. And the advanced stages include wet macular degeneration or development of the thinning of the retina, of atrophy, or some patients can have both, which is another, subtype of patients that we see in retina practice. And so I started that conversation very early. So if the patient does start developing geographic atrophy, we build on that. And as soon as I see geographic atrophy, maybe something that I'm not even considering treatment, like in the beginning of that case, I would point that out and say, look, there's this little area that I'm watching. Remember we talked about it. This is a little bit of atrophy. We kind of reiterate again what's going on, why it's happening, and introduce that there is some treatments, because these are discussions that take a lot of chair time, and we'll talk about probably a little bit about efficacy and safety. these are long discussions. So the more you build on it, the easier it becomes down the road. It's not a discussion, in my clinic at least, that happens, in one sitting.
As a trainee, we actually obviously sometimes play the role of a general ophthalmologist in our resident clinic. So a question for the panelists is, let's say you're seeing somebody with intermediate AMD, or maybe even early GA, like early advanced stage AMD. As the general ophthalmologist or comprehensive ophthalmologist, is it our job to mention the therapies that exist and briefly discuss those? Or is that something where we would wait for them to see a retina specialist to have that brief discussion that there are therapies available and in brief what they do?
I think that's a great point. And I think, as Alexander pointed out, a lot of discussion is always good. And in like any other case, if you see a retinal detachment and send to a retina specialist, the more you talk to the patient in advance, the better it is. I think it would be important not to pin down that you're going to get an injection, because that patient may not get an injection, but just to go see a retina specialist to find out whether you need an injection. And then they come out. And again, I agree with Alexander that many times, we talk with them. Even if I know this is be a good candidate, I never offer that day. I give you the literature, go read about it. Let's come back in 6 to 8 weeks. Decide. And many times the patient even doesn't decide at that point. At a later time point, they may change their mind. One, I think, key for general ophthalmologists maybe is because I know that general ophthalmologists are also very busy. So you don't have time to go through all these OCT images, all these pictures, and do all this discussion. So I think one paradigm shift potentially may be that if you see a patient with dry AMD, and I see it more and more in my own practice, that they just send it over. I look at the patient, I tell them, I don't think you have this, you don't need treatment. As Alexander said, they are always very anxious. So no, you have not reached that stage that requires that advanced stage, so they feel already a lot better. But we already talked to them about it. And then send the patient still follows up with the general ophthalmologist. In the meantime, as they come back in a year, we continue monitoring you. I think that is very helpful. One additional point I think is very helpful also is that taking images. Again, I think Alexander pointed out, OCT images or even fundus photos, because one key decisive point in recommending treatment is rate of progression. How quickly is this patient getting worse? Obviously, your patient was getting worse very quickly, but sometimes you see a patient has an atrophy 6 years ago, and that atrophy has not changed at all, and nothing much has changed. So then one becomes less aggressive on treating these patients. So this imaging, I think, would be very helpful when you see them.
And the imaging is not just important for us in terms of when to decide to pull the trigger, but it can be more or less convincing to the patient as well. You can kind of, share them with the process in terms of like, it looks like this is 30% worse over a 2-year period, or maybe it's only 2% worse over a 5-year period, and maybe we can keep watching it and keep talking about it. So it's powerful in that way.
That's an excellent point. I think that is a key point. And at the end, it's a mutual decision. You're not like, oh, you need treatment. I think go think about it, see what you think. And then you come to a treatment. And that's what Vivek just said, showing that progression rate on images can become very powerful.
And one other comment, we have 2 agents that do slow progression, but these are just the first generation. Just like we saw in AMD, there were treatments that slowed wet AMD, and now we have treatments that in wet AMD that can improve vision in many patients. So I think you should also mention that there are clinical trials too on a number of agents, and there are ocular drugs, there are even systemic drugs that may show benefit. And so that can give the patient some hope that over time, if the treatments will become more effective and will likely be better at preserving their vision.
And
I would assume those details will come from the retinal specialist and from as a non-retinal specialist.
Yeah,
As a non-retinal specialist, there are 2 points I'm taking away already. One is, first of all, as Alexandra mentioned, the word macular degeneration is a loaded word. It's very scary. It's like saying cancer, and it has immediate emotional repercussions. So we're very careful about using that word, and that's one thing to kind of remember. And the second is, I agree that being able to show the images in a screen right next to where the patient can look over and they can actually see what you're talking about and see an actual physical demonstration of what their macula looks like, I think is very, very helpful. And it's helpful even for the comprehensive ophthalmologist, why we would justify perhaps them being referred to a retinal specialist.
John, you make an excellent point. So what I usually tell my patients, you have some aging changes. I think it softens the blow so that
That's dangerous in of itself.
yeah, but I think when you're 70 or 80, you expect some aging changes, but
Right.
I think that's but you're absolutely right.
You know, I was thinking actually another thing that I hear from patients when they're referred to me is, you know, there's this disconnect that we have in geographic atrophy, and that's disconnect with vision, right? As you showed in your case with beautiful images, you know, the patient I think stayed 20/25, right? And so you can see this dramatic change. But if you just check them on Snell and visual acuity, they're 20/25 and they're 20/25. And so one patient told me a very interesting comment, a GA patient. They said, you know, I feel like I'm locked in my vision. I see fine, but I cannot see. And that is I think that's the dilemma and the conundrum of geographic atrophy. So one thing also I think that is very important for the patients that are coming in with geographic atrophy is to acknowledge that. Because patients, I've heard this several times. Patients say, well, I thought I was crazy. Like I thought something was wrong with me because, you know, I've been told repeatedly that my vision is fine, but yet my functionality is not there. So I think whether you decide to treat or not to treat, and, you know, you continue to have that discussion with the patient, but acknowledging their visual experience is very key, and it's very prominent in GA population patients.
And I think
So
this
they often feel, so you know, as a glaucoma specialist, my brain goes to like, what do these people's like fields look like? And obviously it's not realistic for you guys to do visual fields on all these patients, but so it sounds like they're noticing their scotomas, which could be missed by, you know, they're just going for a glasses check and everything's fine in 20/25. Is any part of, could you speak to like the thresholds for treatment for like, do they have to have a certain vision to get to qualify for treatment, or is it all imaging based, or how do you just, how, I guess, more
Now, how do you make the call?
companies, or how do you like
That's what we
who's
wanna know.
getting the treatment, you know?
For I think for both therapies are available, as long as the patient has any form of GA, they technically qualify for treatment. Obviously, there's a lot more nuance in, you know, how much a retina specialist would recommend versus or not recommend a treatment, or have a stronger discussion or less strong discussion with the patient. I think there are a lot of factors involved. Obviously, we chat about a lot of rate of progression, and many times we can tell that if there's a good imaging over the last couple of years. Unfortunately, many times there's not. So that's one discussion to have. Part of it is, at least when I talk with patients, I always let them know that this is definitely not a must do. This is just something that they have an option of doing. And again, either every month injections or every other month injections, they're just not able to come in physically to do it. Obviously, it's just not something we would elect to do. But, you know, I think at least for me, other factors that go into age is a big thing. You know, if it's 95-year-old patients coming into me and they have some geographic atrophy, obviously we're hoping the longer we use these medications, the more effect we get. So at 95, I'm not sure how much of their, you know, the rest of their years they want to come in every month to see a retina specialist. So age is an important part. I think how much vision is for both eyes, whether they're monocular or not monocular, I think it plays a role. So I think there's a lot of different factors that would kind of drive why a patient might or might not decide to have treatment.
I think that, to Becca's point, it is visual field loss, right? That's basically what's happening. It's in the macula. It's not peripheral field loss. And so I think as a specialty, I think we've over the last, I guess a year and a half or about 2 years now, have gotten better at kind of having this conversation, or probably having these conversations earlier. And kind of, I think it's taken us some time, probably as a specialty, to talk more openly about it, even with early GA. I tell patients, you know, if I give them the information, this is going to slow down your disease, and this is for the ophthalmologist as well, it is going to get worse regardless, right? So whether we do the treatment or not, we're just going to slow it down by about, you know, 20% or so. But I do tell them if they want to initiate the treatment, you kind of need to be on the train for a long time because the benefit is only the longer you're on it. So this is not a dibble dabble type of a thing. So if you want to do this, you got to be on the train, and it's a long train ride. So yeah.
When you're talking about slowing down the progression, is that something that you're noticing clinically through your examination and your testing, or is it something
That's a great question.
or is it something that the patient noticed subjectively?
I think
So is
it's
it
both.
objective
the
or
question. Go
subjective
ahead.
or both?
John, I
So
don't think nobody notices that. It is
No.
you have to go through a clinical trial and they look collective images and they compare the control arm to the treatment arm. And then they show that there is a 15%, like it was shown 14% reduction or 18% reduction. But an individual patient, it's impossible for you to know in your clinic whether the drug is doing anything and for the patient. But going back to what Becca, you said, one other way of looking at it is who you wouldn't treat. And somebody with a visual acuity of 2200 or 2150, I usually be much less inclined to put them through getting a shot every month and every 2 months. If somebody has, as Alexandra said, you have a patient with a good visual acuity, like this patient was shown 2025, that one, the one that I see a lot of GA going around, then I would be a lot more concerned about that patient. And I think Raymond pointed out great about age and everything else.
Yeah, all excellent points. The patient that really convinced me that these drugs are effective is one that I treated during clinical trial. This was Oak's trial for pegcetacoplan, who had geographic atrophy in both eyes that were pretty much the same size. And she came back for her 30-month visit. This was in the follow-up study. She had only been getting treatment in one eye every other month. And I went back and compared her GA to when she started the study, and there was a 50% bigger reduction in that GA compared to the initial in the treated eye compared to the control eye. So I think there's a spectrum too. I mean, what we're seeing from the study, I tell patients they have to believe the studies because, as John mentioned, it's hard to sometimes for the patients to appreciate the benefit. But some patients, I think, are somewhat super responders and may do even better than the mean that the study showed. And some other patients may not respond much at all. It depends on where the GA is, the size initially, all sorts of factors, genetic factors we're still learning about. So there's still much to learn, but I'm convinced that they're effective, and I think more so in some patients than others.
I'm
So
glad
to
you mentioned
follow
the
up on
genetics.
that, I was just going to add a little bit. When we think about clinical trials, we obviously have two drugs that are available to us. The clinical trials were designed differently. The Oaks trial that we were a part as well, included patients who were both subfoveal involvement and non-subfoveal involvement. So to answer your question, you can treat either. The Gather trials didn't include anybody who had subfoveal involvement. And now it's really nice because we have the results of the pivotal results of the trials. And for pegcetacoplan, we also have the results of the extension. So these patients now been followed for several years. And what we see, I think, has been alluded to that the effect continues to increase. So the separation of the grafts in terms of preservation of anatomy increases over time. So the longer you treat, the better those patients do. And in fact, the Gale extension trial just recently had a readout, and the patients had, they calculated that it had preservation of 1.5 disc sizes in the macula. So if you take your disc and take 1.5 size, that's how much geographic atrophy you're preventing from progression with continuous treatment for several years. And I think that's powerful, and that's something to consider. To Vivek's point, you need the buy-in for the patient. This is a long-term friendship that you develop with this patient. That's a lot of treatment. And the tricky part that I think we're struggling with, we're so used to in neovascular wet macular degeneration. You see the patient, you treat them, their vision gets better, their pictures get better. Here, we don't have that functional outcome to measure quite yet. We're working on it, but it is a little challenging because I think somebody, maybe Rebecca, you asked the question, you know, what's the patient perception of it? Well, the disease is still progressing. We're trying to slow it down. We're not trying to stop it or reverse it with the current therapies. And we're hopeful that as time goes on, we'll have therapies that can actually improve the vision for these patients.
Are you seeing any of the genetic tests? I know that they've, popping up. I'm sure you guys get bombarded with this, with people coming in with their genetic testing about their risk of macular degeneration. Especially with this specific case, how this patient is so young, would you expect there to be some genetic markers that we know of to kind of help counsel them and their family members?
If a patient has a family member who has, went blind from AMD, I think they have a higher risk. We know what patients get from something like 23andMe, they get certain markers, complement factor H, ARMS2, things that predict AMD, but I don't think they predict yet the risk of severe vision loss or development of CNV or development of GA. We're starting to learn some of the complement factors that predict GA, but they wouldn't see that on their typical testing. But tell the patient, stay tuned. We're learning more every year.
The trials did not distinguish based on genetic buildup of the patient, so they just treated everybody. But the whole idea of complement being involved in macular degeneration came from the Y4OTH mutation in complement factor H, that these patients were at a higher risk of developing macular degeneration. This was the whole basis of people start looking at complement inhibition, but when you look at the trial, there are so many factors involved in the progression, and the progression is so slow that the genetic did not come into background. But I'm sure that your patient probably, because at such a young age, such aggressive, probably has some kind of but we also don't know how the treatment impacts the mutation because the clinical trials did not look at that specifically.
So coming from like a general ophthalmologist lens, that actually leads me to the question. So let's say you're seeing it from in a comprehensive clinic, this kind of patient, and they ask you the question, what is AMD and why do I have it? What do you guys feel like is the role of the general ophthalmologist versus the retina specialist to have that conversation? And when you guys have that conversation in your clinics, is there to what extent do you have that conversation about the pathology and contributing factors when you have that discussion?
You're asking how much of the family history stuff we would.
Well, just in general, like if someone comes in and says, like, what causes AMD? Why do I have AMD? How do you guys have that conversation? Because that also helps comprehensive ophthalmologists maybe kind of, start that conversation off. And then if they're referred to a retina specialist, obviously you guys will have a more extensive conversation.
Yeah, I mean, I would say, what I always tell patients when they say mom or dad had something, or I was like, if mom and dad was 90 when they had their AMD, I think it was because they were 90. But if you told me that mom or dad was in their 50s and they had AMD, then there's probably something else that we can talk about. That's my general kind of quick answer on that. And then I typically go back to some of the stuff Alexander talked about at the beginning. I talk about their smoking history, diet, all these other things that are related to it. And then obviously it is age-related macular degeneration. And I kind of hone in on the fact that it's age-related, obviously, as time goes on. So.
Yeah, I think my conversation is tailored depending on how advanced their macular degeneration is. If they're just early dry AMD, it's generally not too much of an in-depth discussion. I tell them, you have macular degeneration, ultimately it's all due to age. I usually say something like the retina just doesn't work as well as you get older. And there's right now it's really early, really nothing much to do. You probably won't notice a change in your vision for years to come. We'll monitor it. So obviously that's for early. When they get into the wet macular degeneration or geographic atrophy, obviously that's a whole different discussion. So kind of tailor it based off of how much they should worry. Obviously early AMD less worrisome than wet AMD or geographic atrophy.
I think
Makes-
my approach is very similar. I talk about it in terms of things you can and cannot control. And you can control your genetics and you can control time. And so, those things we can't do anything about, but things you can do. And I try to empower patients. And, you would be amazed how people haven't heard about AREDS or they haven't heard about Mediterranean diet. And I've had patients change their lifestyles and probably made them healthier overall. I think the other thing important to keep in mind, there's GA masqueraders. And if you are suspicious that your patient is young, they have a lot of GA, and you get some family history, I've referred patients for retinal dystrophy evaluations because you want to be careful that you're not seeing a GA masquerader especially if you're planning on treating the patient.
I think Alexandra brings in a great point where I agree. I've had patients really change their life because of their diagnosis with macular degeneration. Obviously, people really care about their vision, and it's great when have those patients who this is just a wake up call for them, whether it changes their vision or not at this point. But it really is a nice kind of turning point where they can make changes and have a motivation to make changes. And I think, yeah, stopping smoking, I mean, that's going to save them from a lot of issues if they stop smoking 20 years before they would have otherwise. So it is a really nice way to motivate some patients to change their behaviors and habits.
I just get sort of summarize for the non-retinal specialist, comprehensive ophthalmologist, or dumb corneal specialist like myself. We see a lot of patients with drusen. When do we send the patient to a retina specialist? Getting back to that. Is it based on the way it looks, or is it based on the patient's symptoms?
I would send them when you see the drusen. I think there is no downside of sending them because at the end of the day, the patient always gets back to you. But at this stage, again, we spend a lot more time talking with them. And again, as you said, John, and Raymond, you pointed out, also Alexandra, once you use the word, people get really scared and anxious and so forth. So you need a lot of discussion. Rishab, one of the things I tell patients usually is that it's based on the age when they're in their 70s or 80s, that your body wasn't designed to go this far. And the same with your knees and everything else. You have issues, the same with the eyes. But it's extreme, and that's why you're having it. But the key is, you really don't want to scare them and give them hope. And as Matt pointed out, there are a lot of trials going on with new treatments. We have some treatments that slows it down, and then you have the option if they even qualify. But I think as a general ophthalmologist, again, in the area where I practice, we get a lot more referrals now, even early AMD. They just send them over because these OCTs are not necessarily that easy to diagnose. You do not have autofluorescence. Sometimes the view is not that great through the lens. So, in that way, everybody feels comfortable. We see them say, it looks good, come back in a year. And then that this patient probably is not having anything major going on. And if they do, you had already sent them to a retina specialist, so you buy yourself an insurance not to worry about it.
It's the same way I send a bunch of glaucoma suspects all over the city. Seriously, like any disc that looks any disc that smells funny to me, I'm like, I am not dealing with this. And I will send it somewhere to Becca or whomever because and so same thing. So funny nerve, I send it, funny looking macula, just send it. We'll take a look and we'll just chat with it. Even if if it's nothing, then it's nothing. And we'll see him in 1 year. Sometimes I see just a rare drusen, I'll see him in 2 years, and that's okay. But at least we kind of are starting to see him and start talking to them and stuff.
Yeah, that's an excellent example.
So sorry, I totally agree. There's no such thing as inappropriate or too early of a referral. And we're always happy to see those patients. And in the end, if anything, you just make a patient happier, right? You tell them that it's not not such aggressive disease, and your doctor was so good to catch it early, and we'll just follow you along. And I think it just makes the patient feel reassured. So I think our practices in Cleveland are very similar to practice in Chicago.
Yeah, it's a team effort. We have multiple chronic diseases, glaucoma, age-related macular degeneration, diabetic retinopathy, cataract. All these things, need the optimal care. And I think when we all work together and also include, good optometrists, low vision specialists, we give the patients the optimal care.
I have one other quick question. Does insurance cover some of the new treatments for geographic AMD? Is that an issue, and are some patients restricted or precluded from treatment because of financial issues?
They're FDA approved, so mostly covered, but I'll let the other panelists answer too. That's the short answer.
I think at this moment, 2 years in, I have previously when they first came out, I've had some payers restrict the use. At this moment, I really have not run into any payers who restrict it. Even Medicaid patients, I've started patients on these treatments. So I've not had an issue in the Chicago area recently.
We are having some issues with out-of-pocket costs for some of these drugs, particularly new patients we start them on. And so those are ones where you might want to consider a clinical trial where their care is covered.
Great. Thank you all so much. I want to make sure we're respecting everyone's time and finishing up on time. But, again, I've learned so much, 3 for 3 in these sessions so far about, different ways to take care of our patients. And this has been no exception. And I thank you all so much for joining us tonight. Everyone who logged on to listen and learn, and everyone on the panel, all of our teachers and physicians from IRA, and Dr. Ratinskaya from Cleveland. Thank you so much for joining us. Any last words from Dr. Chaturvedi, our section head of Retina?
No, thanks for everyone coming. Great discussion, Alexandra. Thanks for coming. Really appreciate you joining in and chatting with us.
Thank you for the opportunity to join. It's been fun.
Yep. Thank you, everybody. And we look forward to 3 months from now going to glaucoma, which is our next curriculum.
Yes.
So
Details
thank you,
coming
everybody.
soon.
Appreciate it. Thanks for everybody for joining us.
Vivek, thanks for organizing it.
No problem. Bye-bye.
Thanks,
Good
everyone.
night.
Bye, everybody.
Right.